This study is looking at a new regimen called GCLAM in relapsed and refractory acute myeloid leukemia. And this disease is very difficult to treat when it relapses or is refractory to initial therapy. And at this stage, the only way we know how to cure it is to do an allogeneic stem cell transplant. But the best outcomes after transplant is if people go into transplant with a very good remission. And we don't have a lot of good options at this stage to get people into a good remission. And that was the origin of the study.
Okay, so how was it structured? What did you do?
The study was a phase 1-2 study where we dose-escalated the mitoxantrone within the GCLAM regimen, as there is some evidence that higher doses of anthracycline can have better outcomes in AML. So we took the standard GCLAM regimen. In phase 1, we escalated the mitoxantrone dose, and we determined the maximum tolerated dose to be 16 milligrams per meter squared. And in the phase 2, we treated everyone with GCLAM at the maximum tolerated dose.
How many patients again?
There were 60 patients, 40 of whom were treated at the maximum tolerated dose.
What did you find?
We found a high overall remission rate composed of complete remission and complete remission with incomplete count recovery. The overall response rate was 60%, and the majority of those responses, over 75%, were negative for minimal residual disease, which is an important prognostic marker after transplant. And so the quality of these remissions were very deep for the responders. Further, 17 of the 24 responders were able to go on to allogeneic stem cell transplant.
Okay, so what could be the impact of this research?
I think the impact is that this regimen should be considered as one of our frontline standard salvage regimens in AML, and it should be compared to, in a head-to-head or randomized trial, to other salvage regimens. The difficulty in AML is that there's no one standard, so as part of this analysis we did do multivariable comparison to other standard regimens used at our institution, including standard dose GCLAM with mitoxantrone at 10 milligrams per meter squared, GCLAC and decitabine MEC, and we did find higher response rates and survival compared to standard mitoxantrone and decitabine MEC, where with comparative responses compared to GCLAC. But in the future, I think a randomized trial is the next step.